Got it. Okay, thanks, Julian. Okay, thank you. I apologize to you, all of you that had problems getting in. Julian, it's just set up, it's just a technical glitch. He set up the meeting wrong. And so we're okay now. All right. So apparently we're okay. So good to see everybody. Let's see who all is coming on. Maybe I should re-ping everybody that I'm doing this. We got a lot of people coming in. That's wild. Okay. So on short notice like we did. So all I'm going to do is go back to my email real quick. I'm going to re-ping everybody and just say re-ping. So let me do the reply all. And then let's see, there's the all, and then re-ping, we're on. Re-ping, we're on live. We're resuming our meeting. Okay, I can't read live. Okay, maybe I'll put the thing that, what's that called? The Lincoln, I remember him. He was a pretty good president. Okay, Lincoln, where's the link? Here we go. Copy. And okay, got it for live. Okay, paste, rock and roll. So there we go. So cool. I wasn't know if we're going to get anybody at all, period, on this thing. So it looks like we're gathering a good flock here of people. So let me go get some eyeglasses on. I'll be able to see this a little better. What time is it in Ireland, Mick? Is it 9 o'clock? I just want to make sure I got all my times right.
Yes, Paul, 9 o'clock.
Okay.
We're the same as England now for the last 100 years or so.
That's not here. We'll try to free you up.
We used to be 21 minutes behind them, but they had to merge it for the trains.
Yeah. I was having problems getting on, but I think we've resolved the problem. So thank you very much. And if we don't get more people on, that's fine. I just wanted to get together with you guys and just continue the conversation from before. I think most of you were on. I think I see Sandra there. You weren't on the other day. Andy's on. That's great. And then Brad, you're on. Good. And then Ben, that's interesting. We got to catch up, you and I. So, and Charlie, good to see you. And then who's Doc? As I go through the list here, who is Doc? Department of Corrections, is that what it is? All right, maybe I'll find out. I'll send a note.
It's Clausen.
Oh, it is. Okay, hey, Jake, wow, well, good to see. I'd love to hear from you, just to catch up with you. That's great. So it's good to know you're still alive. It's fantastic. Okay, good. Okay. All right. Doctors, I know who that is, DRS. Okay. And Evan, who's Evan? Remember, who's Evan? Hey, Jeff, how are you? Great to see you.
Hey, it's Evan Weiner, Seminole Tribe Fire Rescue.
Oh, yeah, yeah. Hey, Evan. Okay, good. Okay, fantastic. Joe Zalkin. Okay, Juan is on. Juan, are you doing better, by the way?
Dr. Pepe, I'm still stranded in Colombia with COVID, recovering very fast. I'm doing much better, and I'm hoping that in a couple of days I'll test negative and be able to fly back home.
Yeah, yeah. So tell me, so how is the situation in Colombia? So is it looking bad there, or what's going on?
It's as bad as it is in the U.S. and the same issues with people not wearing masks and everything.
Yeah.
And, yeah, we got infected at a family gathering where somebody was already infected, and the only sign they had was severe back pain for 2 days.
Okay, got it.
Wow.
And a bunch of us got infected, tested positive. But I'll tell you, today's my 4th day, but my symptoms have improved dramatically, and it hasn't been as hard as I thought it was going to be.
Okay, good. Yeah, and had you got your 3rd shot?
Yeah, back in September. I helped a lot.
September. Yeah, okay, got it. So remember we did the test on you, and your numbers were really low back in August, right? So you're probably doing really well. I was in the same ballpark as you and got up to like almost 100%, within
Yeah.
3 weeks. And I've just tested it at 100 days and then also at 133 days. And it's, if anything, it's higher than it was before. It's
Yeah.
at 99.8%. So just so I think that tells us that you can break through, but it protects you. So as you were saying, so that's good. All right, I'm going to get to the formal meeting in a second. I just wanted to see who all was on and was joining us now because it's late notice. I wasn't expecting a lot of people, but well, I'm going to go around and maybe take some reports briefly before we get into any active agenda with some of the folks that we have on the line and just see what's happening in those areas. So, okay. All right, so Julian, thanks again for setting this up. We always have to thank Julian because he's personally doing this and doing it as a favor to us all down there in the San Antonio area in Texas. So we can't thank you enough. All right, so what I'm going to do is first announce that this is a regathering of the Eagles, so to speak, the jurisdictional medical directors, the metropolitan cities across the U.S. and elsewhere. And I don't know if we're going to have a large agenda today, but one of the things I wanted to find out from you all is to see if, and again, this is recorded, this goes out, it's public stuff. So whatever you say, just keep that in mind, but we'll still have fun as much as we can. I was talking to Peter Antevy this morning, and we were saying when people say, what is the Eagles? I say, it's more of what is the Eagles versus who are the Eagles. And it's more of a philosophy of being there to help each other out. And I hope we can continue to maintain that. So the first thing is, and I wanted to find out, is this a better time for some people? And should I continue to do it? And is it better if I did it at 5 o'clock? Eastern time, or should I do it at 3 o'clock Eastern time, therefore noon Pacific? One of my hopes was is to get some of the Australian guys on. I didn't call them directly to let them know, but it's 8 o'clock in the morning in both Melbourne and Sydney, and we're hoping to catch them in certainly Auckland, but I think Auckland's 10 o'clock. That may be bad timing for them, and actually they may have other things going on, or they didn't get my notice ahead of time, but I'm going to continue this for a little bit just to see if we can catch up on some other people, because it's very interesting to hear what's happening there. And I'd rather you get it firsthand than instead of secondhand from me. Okay. All right. So with that, I want to welcome a couple of people. I assume Dr. Sawyer, you're there on with us. You don't have to say anything. You can sit as a fly on the wall, but I do want to introduce you later to someone named Chris Colwell, who's in your neck of the woods, and we'll follow up with you later on. And then let's see. So let's go ahead and get on with a few people we haven't talked to for a little bit. I'm going to first start with Jeff Clausen. If anybody doesn't know who Jeff Clausen is, he's the person who has been more involved with EMS dispatch for the last let's say 50 years now, Jeff. At least close to half a century, anyways, right? And starting off as the medical director in Salt Lake, and then going on to create the MDMS program and so on. And so it's just great to have you back on. Tell me what's happening in Salt Lake, Jeff. I assume you're still living out there, right?
Yep, still in the old hometown, and not much is here. I'm still working full time with the academy, and we've got a now decent size research department called academics, research and communications. Got about 13 people there, and that's been a lot of fun. I always kind of wanted to have, my original goal was to have the Bell Labs of medical dispatch, and it's fun. Try to stay away from corporate as much as humanly possible.
Yeah, well, clearly you've affected dispatch systems across the globe. So thank you so much for all your career. So tell me about Salt Lake and maybe Utah at large. What's happening there?
We're having the new resurgence, which they were just talking about today. Maybe they can't blame on Omicron per se. The cases are going up, deaths have not followed, but we've had an astonishing number of people. I mean, much higher, like some of the states, than even in the first wave. And one of the editorial people mentioned that it's we've been, after the Republicans gerrymandered the new election stuff here, now that the virus is getting even with them and culling the herd. So it's
okay, got it. That's interesting.
One political swipe after another.
Yeah.
But yeah, that's what we're seeing, and I don't see many people wearing masks.
Right.
We made everybody in our organization get immunized. We have a couple of hundred, and we had one we ultimately had to fire.
Yeah, okay. Let me jump back over to Juan in Colombia. Juan, just tell me about the symptomatology, because what we're finding out is that this thing is really, I don't know if the right word is chameleon or chimeric, that it just has different presentations. And then you had a kind of a thing we've been hearing about is back pain. I mean, what we're not hearing is people having the smelling problems or the tasting problems. They're, if anything, they may have some URIs, or some people have scratchy throats, or so on. But the most common thing is a profound fatigue and a profound, just feeling run down. But we're having a couple reports of vertigo in some people, and then in others we're here, and I mean true spins, okay? And in some cases we're hearing about back pain, and I'm trying to understand, is the back pain something in the lower back pain? Is it muscular myalgia, or where is the pain located? Because I understand you had back pain. What's going on with that?
So the back pain is in the thoracic area.
Okay.
I thought at one point, because I drove a long distance. I've been visiting family and friends in Colombia and going up into the mountains and driving for hours. And I thought it was related to that, but it wasn't. It would have been lumbar mainly if it was back pain from driving for hours at a time. It ended up being thoracic. And you are correct. I didn't have any loss of taste or smell. My girlfriend had dizziness. She got dizzy, and she would have what seemed to be orthostatic, dizziness at some point, but it wasn't, because I didn't have it. Again, she experienced more than I did. Scratchy throat, definitely. Headache and fatigue. I had to climb 3 flights of stairs on a couple of occasions yesterday, and I was exhausted just coming up 3 flights of stairs. But again, today being the 4th day, the dramatic improvement in my symptoms is just noticeable. I am 10 times better today.
Yeah. So I hate to, it's a good, but when you say thoracic, it's across your whole back in the whole thoracic region. Is it muscles? Does it feel like bones? Did it feel, where do you think you'd localized it?
It's your entire posterior, rib cage, all of it, but it's not tender. If you don't, yeah.
Okay, that's interesting. And then in your girlfriend's case, you said she was dizzy, but was it the spins kind of thing, or is it just a postural imbalance?
We thought it was postural at first, but then we noticed that even when she was standing, she would take 2 or 3 steps and they had to stop and hang onto the walls because she felt like she was going to fall.
Yeah. Okay. Well, that's certainly different then. So that's interesting then. So thanks a lot. I'm just trying to get my hands around a little bit better about symptomatology. And it probably is like, if anybody comes in and says, I'm not feeling well, they probably got it in this state. Now, any fevers? Because we're not hearing a whole lot about fevers. Some people spike a little fever, but did you have any?
No fever, not at all.
Okay, got it. All right, well, I'm glad you're on the mend. We're looking forward to seeing you. And so thank you so much for everything you're doing down there and helping out the people down there. So I appreciate it, okay?
Thank you, Doctor.
So let me go ahead and jump up to just want to keep a lot of this in Florida as well. And Brad Elias up in Jacksonville, he's our Eagle in Jacksonville. When we were on the phone on Monday, we were hearing that things were very different around the state in many respects, whether you were in Tampa versus Miami or Broward versus Collier or whatever. It's been very interesting. So just kind of curious to know what you guys are seeing up there, besides the obvious, like the emergency departments are overcrowded and so on, and what kind of symptomatology are you seeing up there?
Yeah, for us in Jacksonville, it's a sore throat, headache, fatigue, a lot of URI symptoms, less pulmonary, less fever. Our COVID list of personnel is high right now, probably some of the highest numbers we've seen throughout the whole COVID experience. But we're managing combination of the new guidance with some testing, is able to bring some guys back sooner. Not had to, shutter any kind of stations or anything like that. So we're maintaining daily operations, but we have suspended student ride-alongs and blood pressure checks and all that kind of stuff. The hospitals the numbers are creeping up. The ICUs are, having capacity. They are not overcapacitated by any means. The ERs are filling up though, significant waiting room, wait times and things like that. We're seeing
Yes.
where we're bringing patients in on the rescue stretcher and then being placed in the waiting room because there's no available bed in the ER.
So do you know, is anybody planning to make it, find a different area where they can actually put people in a waiting spot, whether it's using a cafeteria or a tent outside or anything? Has that been talked about or anybody considering that?
No, not at all. We had a First Coast EMS meeting today, and that is, everybody seems to manage. We don't need any type of alternate care site at this moment.
Okay, got it. So good. And let me go down to Angus in the Tampa Bay area. And you work out of Tampa General as well as running Pinellas County. And you're very interested in all the rest of the state, so you could probably tell us a lot of stuff. But Angus, so what's going on there versus what you're hearing from Brad in Jacksonville?
So about the same. I guess the one thing I would say is that although this week's numbers were down a little bit, we maybe have a little more flu here than some other folks are having. We do have a trend line that's sort of following 2018, 2019 flu numbers right now, which is a bit surprising to me. I worked clinically yesterday, and of course I was in the COVID pod, so just about everybody had COVID. Most of it was as being described. I would say we are seeing, I'm told, about 95% Omicron in the sequencing that we're doing of our patients in the hospital.
Okay.
However, I have a couple of folks here, like some of my SWAT team folks, whose clinical presentation over the last couple of weeks sure looks more like Delta. So I think we still have a little bit of Delta in the community.
Yeah, and that's what we heard from John Jew, who can't join us until 5 o'clock your time, and 2 o'clock West Coast. But John was saying they were still around 50-50 in terms of Delta, and but I think they're just behind the scenes, and it's probably by this week they check it out today. It probably would have gone up as well there, so that's but I think most people are aiming towards where you are already. Have you guys? How many of your troops are out? If you look at the EMS in the area, both from Tampa Fire or your county, how many people are out, or what's your staffing issue there?
So I don't have an exact number because we have a lot of different agencies, so I can't give you an overall number.
Yes.
We do have a good number out. We've had some agencies actually reinstitute N95s in the station to try to stop some outbreaks that were going on. But we do have a significant uptick in the number of people out right now. The other thing I would just add is that University of Florida published just in the last day or two an updated projection estimate for this peak, and the headline that's going around in the news today is saying that we might already be at the peak in our area of the state.
Okay, I hope that's the case for your state.
Yeah, I don't know if you know how projections and models go, but that's what folks are talking about today.
As far as the busy emergency departments, are you working on any plans, or is there any policies or plans or anything you're doing to sort of keep people from coming to the hospitals, like either sending people out to cover them or giving them alternative plans to get evaluated or tested? And or are you creating extra space at the hospital for if you have to triage there?
So we have dedicated space for triaging COVID patients, and a dedicated, we basically have an entire pod that's negative pressure now. So COVID's, lined up in the hallways in this one pod. But we have not opened our tent in the parking lot yet. Some of the hospitals are moving towards that. We do have big flashing signs in the parking lot that say, "We're not a testing site. Go to the testing site."
Yeah. Okay. Then how are people doing in testing sites? Because the news here shows people in line for 3 or 4 hours and going, I can't believe this. We have to wait 3 or 4 hours and I have to go home. And now, or it's 4 o'clock and they said they're not testing anymore. We have to go home. So are you seeing the same thing up there?
Yeah, pretty much. I think the average wait reported was 2 hours for the school system testing site yesterday.
Okay, got it. All right. Hey, let me then, because John can only stay on for a few minutes. John Jew, there's some new people on the horn, so we could be a little redundant, and but at the same time, we can probably give us an update. So, John, you reported to me on Sunday that, or Monday, I can't remember which day it was. I think Monday, that you were about 50-50 up in Oregon. Okay, John's at the at the main university and trauma center there, and also an infectious disease specialist. So he's on top of all this stuff. And so, has that changed even in the last 4 days?
Yes, it has changed. We're probably around 70-80% now with Omicron. as
Yeah.
well. It's,
Why do you think you were behind what we were doing here, in Florida, for example?
you want the honest answer?
Yes,
the
I want the
honest answer-
honest. No,
Don't
I want
answer
the-
that.
Here's the big lie.
The honest answer is that we're in Oregon and it was a data problem on Christmas Eve and holiday, and
Yeah.
our data people couldn't get caught up as well. They were on vacation, so the numbers were artificially low. That's the honest answer.
Yeah. Hey, so Joe, it's kind of funny is that I always, people say that all the time. I have to I want to correct it because it comes across when people say, well,
Yeah.
to be honest with you, it's like, okay, I'm going to be honest. You haven't been before. Yeah.
This is a great forum where I usually
Yeah.
be careful what I say. It's like, okay.
Yeah, just say to be blunt. Okay, so that's good. Hey, so let's move on. Oh, it's too bad. Fiona from the UK said she's on annual leave today, so she can't get in with us. Let me move on to some other people we haven't heard from a while. Anything else to report though, John, besides that? Anything else new?
No, honestly, our hospitals, it's very interesting to say, I'm tailing on what Angus says. They've thrown up the red flag and said, we give up. Everybody's got Omicron. And so
Yeah.
they've gone to contingency staffing and bringing everybody back at 5 days here as well. And we're in our EMS system, we're going to contingency staffing in our EMS system and changing
Hey,
our
by the way,
roles.
did you see the abstract that we sent into SAEM that you're on?
Yes.
Neutralizing antibodies, right? Yeah. Well, thank you
Yeah.
for all your help on that. But what I
Yeah.
was going to say is that Peter and I were going to try to kink out something about RT LAMP, but we just don't have enough numbers. We're not that organized yet, but we're seeing some interesting things this week alone. Peter, do you want to talk about that? You sort of mentioned a lot of this on Tuesday, but just for the sake of the people that weren't on before, tell us about the 5-day deal.
Yeah, so we're actually monitoring the return to work, and we're tracking how long it takes people to become negative. So there's two important findings, and it goes along with what John had mentioned. We are doing a Binax now on everybody on their last couple of days, and of course RT LAMP at the same time. And the Binax now, as soon as it goes negative, the RT LAMP goes negative. The average in this, we have a sample size of probably only, just over 20 people. The average number of days for back to work is 8.7, but you have to remember that it's a pretty big spread. We have the earliest we see is 6, but mainly 7s. And then we have a few out there in the 10, 12, and even some 14. But the average is 8.7 days. Again, we aren't testing for Delta or Omicron. I'm unable to determine, at least by my spreadsheet, the vaccination status, if it's 0, 1, 2, or 3. So there's still some data, like Paul said, that we don't have, but it's definitely not 5 days.
And the other thing interesting is that, we have to presume that's infectious at that point in time, but are you, and especially if you were vaccinated. But I'm actually taking the position that even if you're fully vaccinated and not feeling ill at all, that you still could be spreading it. And John, you correct me if I'm wrong on that as an infectious disease person. But so I'm just sort of taking the thing that if I'm out in public, I'm wearing masks everywhere. So in fact, it's so spreadable. I may be wearing a mask during this meeting right now. Right?
It's like, so
Yeah.
Paul, I just want to jump in. This is completely anecdotal information to adding what Peter says. Number one, we just did our breakthrough assays, and there is a tendency for protection with the booster. In other words, I have 3 out of 18 firefighters that are boosted that broke through, and I have probably the remainder, except for 2, were vaccinated. So the quick ID answer is the most likely best protection if you're actually going back to work early is the boosted population. The second group would be the vaccinated population. Included in that group may be the recently vaccinated population and perhaps the prior infected population. And the third one, obviously, is the non-vaccinated. Our non-vaccinated, this is anecdotal ED doctor kind of talk, is that they're coming in just as sick as they are with Delta as well.
Yeah.
So I'm not seeing much of a difference
So
in
this
the
is-
unvaccinated.
again, the 3 R's of education, reiteration, redundancy, repetition, is that no matter where, I think if they come back to work, if you have a policy because you need them or whatever it may be, is that they've got to wear the N95s and it's got to be done properly, not just under your nose or something like that, right?
Yeah.
So,
Right. We've also recommended to go to the KN95 minimum at the station.
Okay.
And during quarters right now. So that's our strong recommendation right now.
yeah, okay, got it. I want to take the advantage of having some of our friends such as Andy Garrett on. And Andy, who's been actually previously the director of the National Disaster Medical System and now is one of the faculty out there and also does pediatric work as well over at GW in Washington, D.C. So Washington, D.C. has got hit harder than almost any place from what I understand. I mean, whether that's anecdotal or not, but that's kind of what is out there. And I was talking to a couple congresspersons. Was that last night, Peter? I can't remember. Was that last night? Yeah. The days are going so fast, and they're just saying it. Just they're in major lockdown there. So, but any event, even though I saw them all speaking today on the floor. But Andy, what's your assessment about what's happening in DC? And are you seeing anything different than what we mentioned in terms of presenting? Presenting symptomatology?
I have, and it's hard to play my day's worse than your day with COVID, right? Because I think it's sort of
right.
The brush fire is sort of everywhere right now. First of all, I want to know how Julian gets a private.
Let me introduce for a second, because I hear this background noise. You have to see what's going by me right now, right at the outside. It's one of the cruise ships going. This is the Regal Princess. Okay, that's one of the Princess Cruise Lines that are heading out today. So sorry for the
man, a COVID culture medium.
I thought you were going to say they were taken to the incinerator.
That's why they have me working here, because there's 8 of them that will come out tonight. So it's amazing. All right, I'll shut up. But Andy, let me turn over you. I'll go mute because I just don't have to listen to all that noise. I wanted to explain what the background noise
it's kind
was.
of charming, actually.
It's different than when people have their dogs jump on their lap, right?
Yeah, I'm not aware that DC is having that much worse of a day than a lot of other places in the US right now or around the world. It's just sort of this rising tide of badness everywhere, as far as I can tell. Certainly the message around kids, and I'm kind of one of the token eagletricians, or what do you want to call it for the group. But if you look at that, we see the light blue, which is the adult cases, which we know are exploding. Now, granted, we don't have a national testing strategy, so it's really hard to contextualize or draw conclusions from that. But you can look at the darker blue lines, which is the pediatric cases added in the last week, and it's gone up like 3 to 4 times in the last couple of weeks, and the number's really, really high, and it's making a lot of work for trying to message to the public, I think, what that means. Everyone's talking about, children's hospitals are getting crammed and overflowing with patients. I mean, the reality is they would do that without COVID in January. That's sort of the MO for pediatric hospitals, but so they're normally pretty full right now. This is, I think, just a classic denominator problem. You've got so many more cases, the explosion of cases, that from everything I've seen and heard from talking to agencies and getting briefed, it doesn't seem like the cases are more serious in kids. It's just the classic denominator problem, and that's clogging up the EDs. And I think the percentages of ICU patients that are related to COVID, I've heard being around 0.2, 0.25, which is certainly 0.25 on top of what would already be a full pediatric ICU system in January. So it's really hard to message what the significance of that is.
Yeah.
Just that we're sitting on a brush fire and the kids are getting burned right along with the adults is sort of how I try and explain.
The next question is, I want to pivot a little bit into, since I'm not hearing anything new from anybody, unless they can pipe in about symptomatology. I want to learn a little bit about how much of this in the kids is RSV that's coming in. Okay. And we were down on flu. And so I heard a lot of people reporting in, for example, in St. Louis last week, there's a lot of cases of fluona, right? In other words, people had flu. John, you were checking for that, at least out in Oregon, maybe a different species, okay? But you were checking, you have a thing that checks for flu, RSV, and in COVID all at once.
Yeah.
Right?
Our hospital probe is a Cepheid COVID Express, which checks for flu, COVID, and RSV. It's interesting. I just checked the map right now flu is very high in the southern United States. So Peter and Andy, are you seeing flu at all in your ERs or at all?
Yeah, I don't know the
Or
percentages,
RSV?
but RSV, flu, asthma, all the normal stuff this
Yeah.
time is raging pretty hard on top of the
Okay.
COVID. I don't have the biogram in front of me, but yes.
But the map is very high in southern US right now. The other issue, just for everybody, it's all H3N2, and it's all that's 99%. And the other one was be the B. It's going to be all Victoria right now. It's 1% right now, so it's going to be H3N2.
So get your flu shots, wear a mask, right?
Yeah. And then our schools are in. That's like so when the kid comes in with the runny nose and cough and fever, it's like I have no freaking idea what you got, but you just need to
Yeah.
stay
right,
home.
right. Yeah, you gotta stay home. Okay. All right. So let's okay, Andy, anything else? Though it's great to see you and have you on. I hope is this a better time for you, by the
Certainly
way?
a better time. I have a standing conflict on the Tuesday Eagles meeting, unfortunately, but and I'll see it whenever the next national meeting is, of course.
Yeah.
Boosters got approved by CDC last night for the slightly younger age group. So get your boosters. My kid's going tomorrow, so
5 to 12-year-olds?
yeah, over 12. So boost up.
Over 12 or boosters for over 12, but they're getting vaccines for 5 to 12, right? Is that correct?
Yep, that's been going for a while, so that's good.
Okay, good. But booster for that's excellent. Okay, how old is your
As
kid?
soon as you can, man.
Yeah, right. Yeah. So
Andy, I have a very nice photo with you from a long time ago.
You
Do
do?
you remember? Yeah. When I was when we were standing up the FIU FAST team.
Yeah. I can't remember the picture, but I would love to see it.
I'll look it up and find it. Yeah.
Thank you, Doctor.
Hey, Eileen, send it around. I want to see a younger Andy as
Oh,
well.
nobody needs to do that.
there is no such thing.
Thank you.
Andy just sort of always stays the same. He's just great. Like he's got youth on his side. So all right, and then it was interesting because both of you guys had worked with HHS years ago together, and that I think that was that's very cool. So thanks. Well, let's take advantage of Eileen while she's here. Our infection. How long can you stay on with us today, Eileen?
Well, I'm sort of trying to do two things at a time because the Surgeon General in Florida just put out the most unpublic health document that I've seen from a Surgeon General ever.
Okay.
And I can't hold back. I can't mince words.
I gotta give you an adult drink, Eileen.
Yeah. It's I mean, there, he's giving a document that's really focuses on personalized health, the health that I would give a patient, not public health. He doesn't understand public health is about population health. It's about the public. It's in the name, public health. Hello, public.
All right. Well, let's yeah. So just
Anyway,
let us-
in the meantime,
Yeah.
for example, right now there's something going on here. We have a faculty member who's today testing N1 and N2. So the CTs were about 26, right? 25 and 26 for N1 and N2 respectively. That's a high viral load. And she's been cleared to go back to work because it's been 10 days.
Got it.
It's like,
I mean, I'm just so frustrated. And this data, by the way, John Jew, your presentation, you should share it with Andy. Have you done that already, or?
no, I haven't. Yeah, I'll share it with Andy. Okay.
Yeah, or it's just he did a really nice presentation of the data. And in fact, if you have it with you, John, if you could just show him real quick some of those graphs and charts you had, that was really phenomenal.
You want me to send it up, or you want me to show it as well?
Well, go ahead and show it. It's it's worth talking about it. It's part of what what I'm dealing with on the side here.
Okay.
Well, yeah.
All right. I'll do a fairly quick, even quicker than I normally do here.
Like I said, I called this an encore and more. So
Yeah.
so people knew what they were getting here.
So while he's doing that, Andy, you told me back then, it was about 2015, and you just said, well, the money's washed up for doing these emergency, teams that you guys need. That's, I'm paraphrasing, but yeah.
All right.
For that.
So here, I think everybody knows this, but this is the best data right now. UK technical briefing. Risk of hospitalization is about 88% for people who are boosted. And it's lower for the non-boosted individuals here as well. And deaths have been reported here as well. The second one is that a lot of the quote unquote protection against hospitalization is not responsible by the antibody. In part, it's probably the T cell response that's protecting most of us here as well. I'm going to quickly go through Omicron guidance because everybody has seen that here as well. But I want to slow down for my docs here, is that there's a lot of, I would say, confusion or lack of clarity on the accuracy of the quick tests, but the ones I've seen have been the BinaxNOW and the Quidel QuickView. There are probably other tests that are out there right now. And there's some nuances on the PCR test where the probes are basically not present in the Omicron. And this is, as of 3 days ago, some of the tests on the FDA site here. The reason I'm looking at this is that our hospital uses the expert Cepheid Express test, where there had been some questions about the lack of sensitivity on these tests. So be careful in over-interpreting your test by yeah.
John,
Go ahead, Eileen.
the Expert Express, isn't that one of the isothermal tests? Do you remember exactly what the technology
yes,
is?
Yes, it is the isothermal. It's the quick test, Eileen. And
well,
it's
which of the, because there's like 5 different isothermal techniques.
Ooh, I'm over my head on that one. So I'll have to go offline on that one. It's the Cepheid. It's the classical Cepheid Express test as well. Okay. That what's new, Eileen, is the panel, with the incorporated panel, as Paul said here as well. But there's some tests there. We talked about the S-drop gene, but this is the what we're talking about. The thing that's responsible for the infectivity is probably the higher capsid assembly and cell entry compared to Delta. So Omicron is much more efficient in entering the cell than Delta is here as well. So from our perspective here, this matches pretty well with, this is the WFIL using original Wuhan, and the culture, as I sort of said before, around 8 to 9 days. So Peter, that actually matches the your issue here. And this is where our culture from a log point of view is showing up. And this by no means goes down to the CT levels here as well. So Eileen can comment it. Kistler et al. Summarize the difference between vaccinated and unvaccinated. I have to be careful here. He looked at Delta. He really didn't look at Omicron, but he found that there was a much more shorter period of infectivity with vaccinated versus unvaccinated. Hence, I think the differentiation between those two groups as far as infectivity is a good reference point, and there's no reason to think that Omicron is going to be much different than Delta here as well. And COVID testing, there's an article by Morris and a preprint here that actually says the following, that if you have to use a test, that the antigen test is probably a better way of determining infectivity than the PCR test here as well, with the usual caveats. And this is probably related to the lack of sensitivity of the antigen test here as well. You can sort of see culturable viruses on the left-hand side and the positive and negative tests. And it turns out that there is a rough correlation between the antigen test as well as the lower infectivity when it turns negative. And Peter really cements that finding here as well. And this is another way of looking at it here as well. So if you had your druthers, and if I had my cake and eat it too, I would have Peter's system here, where you would have a LAMP PCR with a rapid turnaround. If you don't have that, I would use the antigen test to see if you're infective or not. But that's sort of, if you have to use one of the two tests here as well. And that's it.
And that's
Good. And-
wonderful. And I wish
Yeah.
we had the same data as the one you just showed for Delta in terms of exactly how long. We need that data.
We need that
Especially with
data.
these kinds of policy decisions. that are
National
being made.
policies is, I have no data where that policy came from as well. So
Okay.
if you can
Yeah.
find that data.
I
Yeah,
can't, and it's driving me crazy. And
Okay,
it's not matching what we're doing in the lab.
agreed. Agreed.
Hey, so Don, here's where I go and publicly humiliate you again, right? is-
Okay.
No,
Say,
to be honest with you, no, I'm just kidding, right?
Yeah.
But it always drives me crazy because I think a piece of information is datum and data are plural. So it's those data, please. Okay. So thank you.
okay.
And editor.
Great fall.
No, but no, it is great information. And so thanks a lot. And and again, this is for some of you, it's, I had one problem with, can you go back to your second slide? I just want to see it about some of the products up front. Is
Yeah.
that too late?
No, I could do
Wait,
that here.
I fell off the grid. Apparently my internet went down here. And so fortunately I have a cell phone that I was able to use here. So bummer.
Okay, I'll go back to my second slid here.
Yeah. I had been trying to interrupt you, but I don't know if anybody else heard me or not, but okay. So COVID testing, I think it was your second slide, where it was when you were going over.
That one?
Keep going next, right? I can't read anything now, right? Because it's small print, but okay. Yeah, I just want to make sure I understood the rapid antigen test. You were saying that about Abbott Binax Now and Quidel antigen tests are able to detect the Omicron. They are able to do it, right? With very similar.
Yes, they
Okay.
are as well.
Yeah. Okay, good. What are some of the others that are out there? Is it, I'm trying to remember what they are. They're
There's
Binax
about-
Now, in BIOS and all that. You can look up,
Yeah,
there's a list of them.
Right. There's about 20 of them right now.
Mm-hmm.
But frankly, it's I don't think we have the data, and FDA is chasing it right now as well.
Okay, got it. All right,
Unless
thank you.
Eileen knows that data.
Yeah, but at least those data, please. Okay, so anyways, here so where we're going now is that's what I wanted to know. So that's helpful. But for those two, you do have some confirmation that they seem to be good.
Yes.
Hey, by the way, before I forget, today's CME code is one. We actually a whole new, CME for today is 15162. 15162. Well, anyways, we're just so privileged to have a brilliant person like you on, John. So thank you. And you have to get off pretty soon, though, right?
Yeah, in about five minutes here. Okay.
Yeah. Okay, got it. All right, so let's move on, and let's see if there was anything. Oh, I'm trying to find out.
Can you talk about what Peter put out this morning? I thought it was really important.
Sure.
The preprint.
Why don't we have Peter talk about it then, right?
Hold on, I've sent out so many things, Eileen. I'm like an email sending machine. Here, I have it. Hold on. I'll keep sending things until people tell me to stop sending them.
Okay.
Let me bring it up. And this goes back to the antigen testing. Let me share my screen if you don't mind. Let's see, who's sharing? Can you unshare? Would you mind?
Yeah.
John's sharing, yeah.
Got it.
Okay, here we go. And this is Axios. Oopsie, didn't want to do that. Hold on. Let me get that back up. I screwed that up.
You should go right to the preprint itself, which.
Okay, all right. I'll do that. Let's see if I can find it. Let's see. I got it. Okay. So share screen. And here it is. Is this what you're talking about?
Yep, that's scary stuff.
Yeah.
Yeah. So right. So this basically came out of Axios and basically saying that saliva swabs are the preferred sample. And this is kind of what we've been talking about. And we've actually made a policy change here to actually go to completely oral swabs with our Binax Nows. And that it's supported now by this. What we're seeing here, you can see right here, 100% and 86% PPA respectively, and the finding supports date of alter, blah, 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 blah. So let me see here. I don't think this is the entire preprint here. This is just the abstract. What I'll do, I'll send this out here to everybody so they have it, so they can fully read it. But this is in support of what we've put out in our cities, based on what we heard here on the Eagles, actually.
Peter, are
There
you
it is.
doing oral only or oral and nasal?
Yeah, so it's a good question. Whenever, I mean, me personally, I recommend people do oral, nasal, just like the Israelis do. But I get a lot of people who look at me in a disgusting fashion. So I haven't been able to convince everyone to do that. So I would say people at least do oral, but if you're willing to do the old oral, nasal, that's what I would say personally if I was advising somebody.
Well, at least it's not the opposite direction.
Yeah.
Right. Some people don't like the opposite direction. I don't understand that. I would be a nasal, oral kind of guy, but maybe that's my child coming out. I don't know.
But isn't there the thing? Isn't some of these things destabilized with the enzymes in the back of the salivary system? Is that an issue as far as doing oral as well, or is that not a problem, or is it just with some products it would be a problem? Anybody have any information on that? John, would you know?
What's that? Some products have a problem, and so it's unique to it's specific to the problem, to the test.
Okay, good. So that would be good to sort of clarify and find that out. See if it is good in terms of going that route. The other thing is you can do is if you have one of these tests where where you do it, it's the lateral flow test that you put down. You put you maybe do a nasal samples, and then you put drops down on that, and you swirl it around and have it start going up the food chain, and then maybe do an oral one and do the same thing and repeat it. So that's just winging it, and it's not necessarily appropriate, but it's just a thought. It's if we are going to go cowboy on this, so to speak, right? So, all right, Jeff, I think you just sent me a note, and I'm sorry, my whole system is down, so I can't read things like I do. But what were you asking me? Because I can't see it.
No, I was just saying I'd heard the exact same thing you have about oral, the saliva enzymes working, but it was about some of the PCR test. I've not heard that about the rats.
Okay. Okay, so
by the
you
way,
think for the
Peter,
rats?
can I share another preprint that you actually sent? If I could have the screen? Yeah, okay, thanks.
Yeah.
Yeah, so this is the
I think
one
this
that
is-
really,
That's the one yeah.
this is the one that really, this is the fact that there's a discordance with the rapid antigen testing. So this is basically they identified a high-risk occupational cohort of 30 people, and based on viral load and transmission, confirmed through epidemiologic investigation that most Omicron cases were infectious for several days before being detectable by rapid antigen test, even among those who were symptomatic. And so that's a real problem for how we're conducting business. It's a huge problem.
So let me ask you this: do you have a pretty good guess about?
I already put the link on the.
Yeah, but I'm going to say, do you have a pretty good guess about how long the incubation period is? So let's say I'm with a whole bunch of people that have Omicron, or I'm at a party and someone has Omicron, or I was in the car riding with somebody on Friday, right? Just throwing that out, right? When would you expect that I would get symptomatic from it if I had the true exposure? Is it going to be on Monday? Is it going to be on Tuesday? Or is it going to be on Sunday? If I had a Friday exposure, let's say Friday noon. What would you expect?
We're seeing epidemiologically our contact tracers, people are getting symptomatic within 3 days of
Yeah.
exposure.
That's what I've been sort of thinking.
That's about the average.
But so that's the average, but could you see it as early as 2 days and as late as 5
Oh, yeah,
days?
for sure. Yes.
Yeah.
Well, mostly it's sooner with Omicron.
Right. That's what I was thinking. But again, there's some Delta out there still. So in other words, people are asking me, I was exposed to this person. Should I go get tested? When should I get tested? So I've usually said, if you really are concerned, get tested within 2 or 3 days, maybe, and then and wait to see if you get sick or not. And then maybe get tested again if they can. But because some of it is that don't want them to have to go through getting the test, which is such a pain, and definitely not going to the hospital if they're not sick. So, all right. Yes, Peter.
I just want to put up one graphic from the paper that Eileen sent, and this is the one that I sent her today. But it was this graph that kind of got me. This is from that same paper. Just a nice visual that all the reds are false negatives, and you could see here that if it's a square, it's the Binax Now, and if it's a rectangle, it's the Quidel. And you can see here that on day 0, 1, and 2, all of those missed results for
Yes.
Omicron. And I think this is the big take home point, which is why I
Okay.
think I emailed Eileen at 6:30 a.m.
Yes, and I received it shortly thereafter and was delighted that you had sent it. Because, you know, I mean, how can we make policy when we're using the wrong tools?
Yeah.
Yeah.
All right. So, hey, listen, let me now get around to a lot of people that are on the call today that I haven't talked to for a little bit, and like to, I'm trying to see who's on the list here again. This is terrible that I don't have an internet connection. But so a couple of people I will be wanting, I'm going to want to talk to Ben up in Milwaukee in a few minutes, Doug in Pennsylvania, and specifically, but first I want to hear from, and then later if Mick is still on, I don't know how late it is there. But Joe Holly, can you tell me what's happening in Memphis? And later I'm going to come out to you, Mark, I hope, and Mike Sayer out on the West Coast. And more importantly, I'm going to want to get to Rob Dunn for sure, because I haven't talked to him about, and Ron Roth. Okay. So, but let's start with you, Joe, because you have an interesting and amazing situation happening out there in Memphis, right?
Yeah, we do. Hi, everybody. I posted the comparison of the numbers. I just thought you'd find it interesting. I have hard data from January 1st versus January 6th today, and noted that our hospitalizations have gone up double, as have our adult ICU and pediatric adult ICU admissions, pediatric inpatient admissions, and about a 50% increase in pediatric ICU admissions. So we've got, we're seeing similar trends to what everybody else is, meaning there less ICU utilization, but a lot of hospitalizations going on, and our EDs are absolutely melting down.
So what are you doing about that? Are you doing anything with either the EMS system or the hospitals? What are you doing?
Both. Part of the issue has been the health department has not been very robust recently in increasing the availability of testing. So a lot of people showing up in EDs for tests and pushing on the hospital systems to get their tests done, overwhelming demand for testing and not enough capacity for testing. A significant number of healthcare workers out, both on the EMS as well as the hospital side. Although the new CDC recommendations are having some impact on that, at least getting people back to work sooner. I expect we will probably infect a lot of people in the process of doing that, but we're hurting bad enough, I think, that they're beginning to pull people back anyway. Hospitals are looking at anybody who's been out or exposed would only work in the COVID areas kind of thing, just to sort of help prevent what spread they might be able to help prevent. A few things like that. Other than that, it's moved so quickly here that it's been a real struggle trying to keep up with it, as opposed to Delta.
Okay, got it. All right. Well, thanks a lot. So let's jump up to a place that's always had challenges but has great response, which is up in Detroit. Rob, how's things going? How's the mayor doing? How's everybody else doing up there? Let's tell them all I said hi. But what's happening with you?
He's getting sworn in for his next term tomorrow. So
right.
We got him for
Good.
4 more years.
And
And
he has you, does he have you for 4 more years is the question.
oh yeah, I don't know. We'll see about that. He's got me for a while though, is I think this got mentioned on one of the prior calls. I was appointed as the interim medical director for the city's health department.
Right.
When our health department medical director moved on, which is good because then I can kind of use my own agenda sometimes. And one of the things, our biggest thing has really been trying to prevent what Joe Holly's talking about, is that we have expanded our access to testing. We've always had a huge testing presence. Many people will remember seeing the pictures of Detroit at the very early phase of the pandemic, where we spun up a large drive-through testing at our state fairgrounds. And it was honestly the only testing in the state other than the state lab for a period of time. And now we had a need for it for sure. We normally get for our own kind of community employee outreach testing, 3,000 per week test kits using the Abbott ID Now platform. We upped that to 4,500 mid-December because we knew we were going to need them. We have passed out about 30,000 home antigen kits. We have Binax Pro kits that we do use a lot for the back to work piece, as some of the people were talking about in here based on some of the same analysis. And then we just recently started using the Tempus saliva PCR. I don't know if anyone else is using that. I'd love to hear from you offline if you are. That's been pretty successful. They've got a pretty quick turnaround, and it's very easy to do, particularly for some of our outreach and follow-up testing. So that's really reduced the lines. We have an online appointment, and it's taken the pressure off, especially during the holiday when you could not get a test at a lot of drugstores and clinics. So that has kept people out of the EDs. We've tried to do a lot of messaging on that. You know, the other thing I just want to talk about briefly is kind of the back to work. We have always had a testing strategy to get back to work. You have to have a negative test. Every City of Detroit employee, all our first responders. Our hospitals have a lot of variability, which I'm seeing on the chat right there, which some of that's kind of crazy. We do have one hospital that just out of the blue decided they were going to be crisis standard on that CDC matrix, despite the fact that they've never asked for help. They've never said they had staffing needs. They've never had any issues on any of our regional healthcare coalition meetings. I think we kind of reeled them in a little bit and helped them do some things. But that is an ongoing challenge in our health systems, getting people back to work, to the point where some of them had very limited testing, and we were doing their testing for them through the health department to get their employees back to work safely. You know, it depends kind of where things go on the numbers, whether we'd have to move to a contingency on some of those, but we have not had to do that yet. I have a bunch of people out. I got about 15% of our first responders out right now, but again, with pretty aggressive testing and cycling back, you know, we're seeing a lot of people get better very quickly and test negative very quickly, and not seeing the persistent positives that we were seeing in some of the prior waves, which is good because there's been a lot of people out. So,
Yeah.
And of course we had some massive snowstorms and near zero temperatures during the middle of this.
All right. Well, listen to me. I got to make sure I get on to the other people. Well, thanks. It's just great to see you. And thanks as usual for your contributions and mostly for your day-to-day work up there in a really challenging environment. And just, you're doing a fantastic job. Very proud of you. That
Well,
sounds
I
like
want to thank everybody here because I reach out to everyone on this call all the time. So
yeah. Boy, yeah, I understand real well. That's what this is about. Like I said, when we began, it's not like who we are, it's what we are. So I thank you guys for looking out for each other. Let me go over to Mike Sayer in Seattle and jump on, just since we're in the Northern Hemisphere there, right? Let's head over that way first before I get on to some of the other folks I talked about. Anything to report there, Mike, from what we talked about last week, or, well, it was 2 days ago or whatever it was? Yeah. Are you still there, Mike? Mike Sayer? Maybe we lost him in the interim.
I think we lost him, Paul. I don't see him on your screen.
Okay, got it. Maybe that's it, because I warned him that he was going to come on, that I was that he got off as soon as possible, right? Well, then if you're on, Mark, let's go. Let's go down to San Jose and see what's happening.
So yeah, I spent all morning in meetings with the hospital, the city. We're having the same issues as everybody else. What's interesting is that we have a very, very high number of COVID positive patients in-house at Stanford Healthcare, at Stanford Medical Center. The internal medicine folks actually did a manual chart review of every single one of those patients. And what was interesting was that very, very few of those patients were admitted for respiratory symptoms. They were patients admitted for other reasons that ended up testing positive for COVID. And the patients who are in the ICU with COVID, most of them are actually still Delta. So we're seeing a sharp decrease in the patients admitted for respiratory symptoms with Omicron, and certainly none ventilated, and very, very few in the ICU. Anecdotally, I can tell you that I admitted a patient with an infected kidney stone who ended up surprisingly tested positive, and she was shocked because she didn't even have a runny nose. Dealing with the same issues as everybody else in terms of staffing. The last Sunday, we were able to staff just over half of our ambulances countywide due to positive cases. And so the questions that I'm starting to hear both at the city level and at the hospital level is, when is our mitigation strategy starting to be worse than the actual disease itself? Because our responses to STEMIs and codes and traumas is delayed now. And we've had to again put a hold on elective surgery because of staff outages. We have well more than 800 people out at Stanford who are COVID positive. And we're just kind of riding the wave like everybody else.
Okay. Well, thanks for the report. It's just great to see you. And thanks again for a great job. How many people in your EMS force and fire department got vaccinated? Because you were fantastic at getting so many people vaccinated. I
think we're well up into the upper 90s, 97% for the fire department. EMS is the transporting agency is a private service, and they will not report it to us. And we're somewhat lower on the law enforcement side. One of the issues that we had was that the city kind of caved a little bit and granted a medical exemption to anyone who applied for one without any particular rationale behind it. They just didn't want to fight it. But the state mandates have kind of overwhelmed that, and we've seen a lot more people getting vaccinated in the past several weeks.
Okay, got it. Hey, I just want to see, it's Roxy said have to run, but so if you're off, that's fine. Otherwise, you're in California. I thought I was going to hook up there. Are you still on by any chance? If not, I'll catch him next week. Okay, let's see who else I want to. Ron, Rob, what's going on in sunny Pittsburgh?
Same as everyone else, our cases have skyrocketed. Our number of providers with COVID, even though our EMS is over 97% vaccinated, they're going up. I just have a question for the group. We've been sort of bouncing around it. Maybe I missed the punchline. We're going to go to the CDC guidelines to get people back. But what percent of people can we expect to still test positive with antigen tests at day 5? And I'm getting the sense that maybe the vaccinated population may be different than the unvaccinated population.
Yeah, John's not there anymore, but what I heard from him saying is that it's sort of, you have kind of a tier, which was all intuitively correct, which is that if you're boosted, you get better quicker. If you're vaccinated, meaning not having been boosted yet, but you got the 2 shots, then you'd be the next tier. And then finally, unvaccinated, it just takes longer to get better. And I think that all kind of makes sense. And I guess he's actually seeing that or reporting that. And then again, we have Peter is looking at some of the average people, but Peter, have we broken that information? I know it's preliminary, it's not enough, the N is so small. But if you broke it down according to vaccinated versus unvaccinated, where you're seeing people still positive at day 5 and 6 and 7, or sorry, yeah, I guess that's a good question. Are you still there, Peter? May not be, huh? So we may have lost him. I'm so sorry that I didn't get to everybody tonight. But I think that I'm going to try to find that more information for you. But there is that John's creating a tier where he is. Based on that. Did anybody else hear anything different or anything else we should say about that? Either way, I think the bottom line you heard me say was make sure they're not only wearing N95s, but or at least KN95s in the station, et cetera, and wearing them correctly, okay, and using them that way.
We cannot get fired to do that.
Mm-hmm. Yeah.
I don't know what the issue is.
Yeah, that's why we're so lucky. That's why I'm always in awe of what Mark did and that was a lot due to Mark, by the way, out in San Jose. So that's interesting. All right, well, we'll try, if you want, email John and get back to him on that, and Peter and Tevi as well, if you want to get the information. I'm sorry that they both dropped off now. So, but I hope that helps, or I could call you later too, one-on-one, so I don't take up the time. Would anybody else say anything different than how I replied to him? Hearing none, we'll pass the motion. Right. All right. So, well, good, but it's great to do you think you had a super spreader event on Monday night with the Rothenberg, with the route there in the stadium?
I guarantee it.
Yeah, it was amazing. So I didn't see many masks on people who were shouting and screaming for Ben, 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 so. All right, so if you don't know what I'm talking about, they had sort of final season game, Monday Night Football. Well, not the final season, I shouldn't say that, but the final one at the stadium there in Pittsburgh on Monday night. So there was a lot of, let's say, enthusiastic audience members. None of them were affected by alcohol, I'm sure, right? So, and then Ron, you're actually the medical director, so to speak, or for such events for the Pittsburgh Steelers, right? Are you still doing that? Am I right about that?
Yes. What's funny, the NFL mandates that us to wear a mask on the sidelines, which is probably safe. At least in Pittsburgh, where if you're in the stadium, in the bowels of the stadium, you're also supposed to be wearing a mask.
So go ahead. Yeah.
Yeah, they used to test us before each game. They don't now.
Okay. So actually, if you don't mind, we maybe not instead of getting you on the spot right now, but maybe give us a nice little report, a 5-minute, maybe 10-minute report on what it was like to be an NFL, doc, and what changed and what was new and what are your reflections on it and what you would advise, that kind of thing. It would be kind of interesting to hear. And I'm going to ask Mick to talk about that sometime as well, maybe, because Mick's done the same thing over there in Ireland as well. So, which is a good chance for me to skip over to Mick then. Mick, kind of anything to report new, because from Ireland, because I know you have 98% of the people over 12 vaccinated, and about 55% boosted, but you're being overrun by Omicron, right?
In overrun, yeah, we'd another record day of cases today. So as I said in the chat, the last 10 days, we've had more cases than we had in all of 2020. And it got to the point where the testing system is overrun. We had been doing PCRs, walk-in centers for the public, but because the public couldn't get a test the day they wanted, they would rock up to the emergency department, which resulted in a big surge in attendance at the emergency department for people looking to get a test. So the authorities took that on board and then suggested anyone between the age of 5 and 39 should be doing an antigen test, and only if the antigen test is positive, then to book a PCR test. However, yesterday they had a concern about some of the antigen tests being sold. They're currently testing them. One brand, GENRUI, has been taken off the market. I put a link about it up above. It had an excessively high number of false positives, and that was the cause of that brand being taken off the market. Hospitals are still under quite a bit of pressure now. I uploaded our stats for where we are with COVID in the hospital capacity. There are 7 ICU beds available in the country at the moment.
Oh, that's just extraordinary. So, and have you, as a sidebar, anybody have any questions for him, by the way? Okay, well, if not, one of the things I was going to ask you about is that if you could come back and talk about things as well, as far as the, being responsible for running major events such as soccer, football games or whatever else.
Oh, that's an interesting one. Sorry, just about that. So the next month is the start of February. Is meant to be our big rugby competition: Ireland, England, Scotland, Wales, France, and Italy. And because a number of the countries have now limited attendances to less than 5,000 again, the competition organizers don't want to have games in countries with limited attendances, and there's unlimited attendances in the UK. So they want to transfer the whole competition to the UK, which is causing a little bit of upset because we have another competition for the level below that, which is the provincial teams. And one of our teams went to South Africa recently and was there just as Omicron was breaking out. And of the 55 people who went, 25 had to stay in South Africa for 10 days. They didn't even get to play the game. Within a day, they had a lot of people infected. And when they came home, then they had to pull in guys. It'd be like, I suppose I got to go to where I worked in Boston. It'd be like the Patriots pulling in guys from what do you call it, Jimmy G's high school team to play for the Patriots. And that's exactly what happened. They had 18-year-old and 19-year-old guys pulled in to play for a game against the big team in the UK. So they don't really want to expose the players too much, but at the same point, they don't want to not have games in the country where the game is meant to be. So it's causing a little bit of upset.
Got it. Okay, well, that's interesting in itself. So thanks for the interest, just always interesting story. Okay, so let's do this. I'm gonna see if my phone is, I want to make sure it's off. Let's see who else is in the chat. Is there anything else going on that I need to know about? I think we're okay on that end. All right, so who have I not gotten on? Hey, DRS, namely Jan Skarsky, you want to say anything or pipe in, or just we can just leave you a go. Don't say anything if you don't. I just wanted to know if you were there, if you wanted to pipe in and ask any questions. That's all that you're there.
I'm pretending to be David. My name is Ainur Sawyer.
Hey, how are you? Yeah.
Thank you so much. This is fascinating.
Okay, good. Hey, so, do you go, is that how you pronounce your name? Zayanar, is that right?
Ainur, yeah.
Ainur, okay, good. So thank you so much. Well, do you mind telling us who you are and what you do? Because I kind of know, but I just want to do an introduction to the group. Has this been interesting for you so far?
Oh, fascinating, yeah.
Okay.
I'm on orthopedic faculty there. I run the skeletal health service, but I also run the UC Space Health program in University of California. Do a lot of work in space medicine and remote medicine, and ended up early on in COVID working up how to do community testing. So we set up the Bolinas Testing Center here, and then just like everyone, putting in whatever capacity I had in different ways towards this. But I'm very excited to listen into this. This is fantastic. We're swimming in the same swamp that all of you are. We've been lucky in the Bay Area to have pretty like-minded people, high vaccination rate, et cetera. But right now we're having one of our biggest surges, and we're back to cutting out elective surgeries again. We're overwhelmed in terms of, it's a combination of staffing shortage and just sheer volume. Like everyone else has been saying, not as many, certainly intubations. I think we've got 8 in ICU and
Great. Just one, so just let me interrupt you. There's 2 things, because I want to get on to some of the other folks. I want to get everybody off here pretty soon. 2 things is that, one is that I may actually, I don't know if you'll be home, but I'll be in your neck of the woods, so to speak, next Sunday, a week from Sunday, like about whatever it is, 9 days from now. So I'd love to meet you directly. And then secondly, I'm going to try to get you introduced to the chief of the emergency department at San Francisco General in Zuckerberg, Chris Colwell. If you don't know him, just a really good person for you to know, because he's like one of our real key people. He's really tied up today. I guess there was a big issue with one of the cruise ships there in town, and you'll hear about that if you haven't heard about it already.
I also want to introduce you, because I do work in Antarctica with the Australian Antarctic Division, and we're doing actually a quantitative monitoring in conjunction with their quarantine program, because Belgium obviously just had infections in Antarctica, but they're doing everything they can to keep COVID out of Antarctica. And Jeff Ayton, their chief medical officer for the AAD, might be very interested in this if he would be allowed to listen in at some point.
Yeah, I'll say I'll talk to them up front, and all that. And then actually, if you saw the invitation that I put out, I even put the Edmondson Scott station on there, the time for it there.
Yes. Okay, thanks.
You saw I caught up with that. Hey, so it'll be great. I hope that you're going to be around next Sunday, as I was talking about.
Yes.
Not like 9 days from now, whatever it is, 9-10 days from now.
Yes, that'd be great.
Okay, good. I'll see you. And David's not on right now, right? You're just using his thing there, correct?
was here but had to leave, so he allowed me to stay listening.
Yeah, that's fine then. Okay, good. Oh, now I understand. I just want to make sure I understood what was going on. So I'm looking forward to seeing you then. All right. In the meantime, I'll get you plugged in with Chris Colwell, Dr. Colwell, again, as we do that. So thanks for taking the time to be on. Let me quickly switch over to Doug Kupis. How's things going in the state of Pennsylvania, let alone in your neck of the woods?
Well, I think Ron gave you a little bit of a information on Pittsburgh. I think, it's like everybody else has been describing. We have two worlds. We have the health system that is overrun, and we have the rest of the world that doesn't think anything's going on. I mean, throughout Pennsylvania here, I see convenience stores, barber shops, Walmarts with like nobody at all wearing a mask while I'm in there with my N95. Literally most places, if you wear a mask, you're the only person. And the health systems are overrun. We're seeing more hospitals go on diversion, even tiny hospitals that never did that for periods of time. And not that tends to help the situation at all. Long lines for testing, as everybody's having. I think that a little bit of the difference is that a lot of the things that were in place a year ago have been taken away. So even though this is more of a surge of patients than we saw a year ago, the supplemental tents outside of emergency departments and that sort of thing have been largely taken down and don't exist anymore. So I think those extra steps that were taken in the past have not been brought back, and places are just sort of dealing with it as they can.
Okay.
A couple people, there were some, there's been some banter just from my NAEMSP hat on. NAEMSP meeting is still a go. Everybody will be required to be vaccinated, indoor mask rule in California. So that is still a go. Some questions have been circulating from people here and there, but the board wants everybody to know that that the conference is on, and there is no hybrid or virtual version to watch next week.
All right, got it. Well, I'll see you there. And so thanks for everything you do, Doug. Anything we need to know about that either that is going on or issues going on at the NAEMT, National Association EMTs level, so you're the medical director, or the National Association of EMS officials, state directors and so on, and medical directors?
Yeah, so next week, NAEMT is having their board meeting in LA also. I am going to miss it because of the conflict of the NAEMSP meeting. But I would say that probably the big excitement related to all three of those organizations, the thing that ties them all together, is just within the last couple of days, the final version of it's about 12, don't count me on the exact number, about 12 organizations did a position statement on the use of lights and siren for emergency medical response and transport.
Yeah.
An update from the 1994 version that NAEMSP and SEMSO had, but added about 10 additional organizations and dramatically updated it. And that's out to the organizations for final approval. And it includes a much broader group of organizations now with I-Chiefs and International EMS Chiefs and IAED and various other organizations, but NAEMT, NASEMSO, and NAEMSP are on that too. So we're just waiting for official formal approval from all of the organizations. So that's exciting.
Okay, of the remaining people, first of all, is this second meeting helpful to you or just redundant, or is it helpful because it continues to have more discussion on it? You were on the other day, weren't you, Doug? I can't remember, for a while on Tuesday, right?
I was on. I mean, if my 2 cents in it is that there is so much changing so quickly right now. To hear this perspective from all over the country and all over the world a little bit is helpful discussion.
All right, I'll keep doing it then for now. Is the timing good for you? Should I be holding it earlier, like at 3:30 Eastern time or 5 or 4:30 Eastern time? Or, by doing it this hour was hopefully an attempt to get the Australians on, which it didn't happen, but whatever.
I would ask
Yeah.
the whole group that. Yeah, I don't want to answer for the whole group on
Yeah,
timing.
I'll put a survey out as what I think I'll do. So, okay, just anybody else have any response to that or any?
It's could be variable depending on how many times my schedule gets pinged. So, but
Yeah.
I think it's very valuable.
Okay, good. So the only persons I haven't talked to, it looks like that's remaining, it looks like Karen Thurman and Joe Salkin. Karen, anything you want to pitch into us here today?
No, sir. I'm a air medical provider, and we're not really finding that much with COVID right now. So no, not really. I just find this very interesting, just seeing what's going on in the various hospitals and just listening to try to keep our team safe as well and try to figure this all out. So I just appreciate everybody's input.
Have you guys been, just wondering, have you done anything different within the cabins? Because obviously you're in a closed space. Are there things to circulate air better there, because you are flying through space, so to speak? Or have you done anything along those lines? Or are you using like what's that mask that they're using that has the really good filters and all that? I'm trying to think. I actually presented it at the Eagles meeting this year. I can't even think of the name of it. Oh, the safety net. Are you guys using anything like that up there? And have you done anything else in the cabin to improve the conditions aerosol wise?
We just try to really limit anything that's aerosolized. Of course, all of our PPE that can sometimes become a challenge with night vision goggles, helmets, and whatnot. But we still, wear all of our N95s and goggles and gowns. But there are some transfers of patients, but back in the peak, there weren't that many transfers because hospitals weren't really accepting COVID transfers. Everybody had to pretty much take care of their own unless a facility could provide something specialized like ECMO or STEMI. So we didn't really see that much, but anything that we tried to do or had to do that would be aerosol generating, we tried to do it not in the aircraft and just be very cognizant of that. And it is nice. We can really open some windows up and air it out very quickly.
Yeah.
If we need to.
All right. So then the only thing is Joe, and I'm going to try to wrap this up. We've been on for quite a while here today. So, but it's been really interesting and good to catch up, everybody. Joe, anything to report from I assume you're in Carolina, right? North Carolina?
North Carolina. Yeah. Thank you, Paul, for the invite to be on with the panel. I shadow you through the Florida connection, and it really is great information week by week. North Carolina's got National Ambulance contract folks here, FEMA ambulances, about 20 in the state. Wake County's got 4 assigned to them, the larger cities do. This is a second round that we've had them here, and they're very helpful to take a little bit of the load off of the locals. We're concerned about staffing and retention, and whatever the CDC is recommending week to week to try to be in compliance. It's very difficult to get HR people to accept the fact that folks will come back without a PCR test.
Yeah.
So we're dealing with a fair amount of bureaucracy that doesn't move as quickly as new guidance comes out. That's about it.
Yeah, because probably what they're doing is they're talking to the city or county lawyers, and you'll never get an answer because everybody's in a CYA mode, CYA. Okay, and so that makes sense that that's happening. It's a shame that it's happening. So that's good. Well, thanks for participating then and being on the board. Do you find that both the Florida meeting and this one helpful then?
Absolutely. And I cross-pollinate with the North Carolina crowd and my NMSP cohort as well. Communication is the key. I mean, kudos to y'all to be able to do this week by week. I wish I could gather my medical directors once a week and have a similar talk. So yeah, I do find it interesting.
Well, one of the interesting things I thought was, well, obviously like on Tuesday's meeting, we had people from, not only like Ireland, but UK and France and all that. And it's just cool because I remember last year we heard about people having smelling problems yeah, I think as early as February or early March, not last year, but the year before, when this thing first started, where people didn't even know what this thing, we hadn't even named it COVID yet or called it a pandemic. And we were hearing that this rash of people were coming down with it. So we consulted our ENT guys. They came on, they confirmed, yes, we see this with coronaviruses in general, but not to this extent. And so we started telling whatever we have in the United States alone, 161,000 paramedics under the Eagles, that kind of thing, to look out for that. And then, of course, 2 months later it became common knowledge. But it's just kind of cool to have the boots on the ground where people can tell us that we see signals and we follow up on the signals, just like the stuff that Peter presented today. And I think that's what's really great, and communicating and learning from each other. Like, like what Mark has done has just been phenomenal out in, in San Jose, getting people done. And yet it's kind of interesting to see what happened with Nick. You have so many people vaccinated in your country and still seeing the problems that you're seeing there. So it kind of gives us an advantage to know what's going on. And then I guess there's one more person before I get off, is Greg DeWitt. Anything you want to say from your area?
No, not really. Just we're seeing a little spike here in Southwest Florida. In our fire department itself, we've got like 8 people out, but we're doing testing per the CDC, and other than that, just a few little spikes and everything's pretty good. We do have at least one monoclonal open up in our area too. So they do have some product.
Okay, well, listen, everybody, just want to say, I think it's time for us to wrap it up. I got to head up to West Palm Beach tonight, got some duties there. And so I got to get packed up and get on the road. But having said that, keep in mind that the CME code for those who are still left there is 15162. So you can still claim that and get the hour and a half for that, for those of you on for whatever time you're on for. So, okay. Thanks again, everybody. Either way, I'll see you Tuesday. Okay. Same time, same station, not this time, but Tuesday morning. So, all right. Thanks again. Bye-bye.
Thank you.
Mick, thanks a lot. Thanks for being here, Mick. And Rob, as usual, you're the best. All right, see you later. Take care.
Bye-bye.
Bye, thank you.
Thanks, Eileen. Hey, Eileen. Okay, well, I'll talk to you later then.